And patients will generally see, if you average it out, a weight loss of 8 to 10 pounds per month, which is fantastic. They've never seen that before. But the thing is, the weight stays off this time.
Thanks for tuning in to Conversations with Betty LaMarr, coming to you live from the Bluff City. Conversations is weekly wall-to-wall talk about all things Memphis and the Mid-South. Conversations with Betty include people just like you, living on the Bluff, doing what you do to uplift the city of Memphis. And now, your host, Betty LaMarr.
Hello, and welcome to this special edition, Medical Talk on Cable Tonight. I'm your host, Betty LaMarr. And I know that you all have been enjoying this series that we're doing, and it's all about your health and wellness. And your health and wellness is all about how you treat your body. Your body should be your priority. Now, we're talking about obesity and bariatric surgery. Now, you know we've had Dr. Robert Wegner with us, right? He's back. And yes, and as always, this show is going to be off the chain. Good evening, Dr. Wegner, and welcome back to Medical Talk on Cable Tonight.
Thank you, Betty, for having me back. I think tonight's going to be exciting. We're going to get into the guts, so to speak, of the procedures of bariatric surgery and really get into it tonight. So I'm excited to talk about it.
Okay, well, for our viewers that are just tuning in, tell them a little bit about Dr. Robert Wegner as it relates to our topic of discussion this evening, bariatric surgery.
Okay, so I'm a surgeon at St. Francis Hospital. I only do bariatric surgery. I essentially do, two procedures: laparoscopic gastric sleeve, laparoscopic gastric bypass, which is what I'm going to talk about tonight. I've been in the area for many years and been able to help thousands of patients with treating their obesity, which, as I said last time, is now classified as a disease. It needs to be treated as such.
Okay, well, being that this is the second segment in this series, okay, if you will, just recap what we spoke about last week on the show. So
one of the topics that we want to bring back to the forefront of the discussion is, what is BMI? What does that mean? When we talk about obesity, we need to do it in an intelligent way. And as I said last time, we don't want to treat the obese patient, the morbidly obese patient, and cast blame on them that they have this disease because of it's at fault of the patient. We know now that it's clearly metabolic, it's clearly hormonal, it's physiologic. It is a very complex and multifactorial disease that we're trying to treat. So it's more than just telling the patient, hey, why don't you eat less and exercise more? There's so much more to the treatments than just prescribing those two things, which unfortunately is what the patients are told most of the time throughout their entire life by their loved ones, their physician, or people that they talk to. They say, why don't you just eat less and exercise more? There's just so much more to it. So when we talk about BMI, body mass index, I encourage the viewers to go to their computer, go to their smartphone or their Droid phone and type in body mass index, BMI, and there'll be a calculator. The best way to do it is to go to my website, where it's www.memphisweightlosssurgery.com. And on that website, there's a BMI calculator. The patient can put in their height and their weight, and the BMI will come up. Now, if the BMI is greater than 35, you are a surgical candidate. So, that patient, that person should be paying very close attention tonight, because what I'm going to talk about is directed at them. The BMI of 35 is the low limit of surgery. My average patient has a BMI in the mid to high 40s. So BMI is actually 35 is low for my operative cases, but that is the current standard for an operation.
Okay, so how prevalent is it, Dr. Wegner, obesity in the country?
Obesity is a disease that has grown exponentially, no pun intended, over the past 5 to 10 years in this country, but actually, throughout the world. The data was just released for the first time in this country. The number of obese Americans outnumbers overweight Americans. According to the CDC, up until the data to about 2012, in 2012 there were about 65 million people with a BMI between 25 and 30, which would make them obese. Remember, BMI over 30 is morbid obesity, and those patients are numbering 67 million.
Ooh.
So now you've got obese patients outnumbering overweight patients, and that's never happened before. So, you know, the drivers of this are clearly lifestyle, food choices, the quality of food, the quantity of food, stressors in our lives, behavioral issues, and you need to look at all those things when you treat it. But it's especially prevalent here in the Mid-South. If you look at a map of the country, the prevalence of obesity in this 3-state area, which is, you know, Tennessee, Arkansas, Mississippi, about 1/3 of the population, greater than 30%, has a BMI over 30. So that's, you know, tens of millions of people here in this area that would benefit from surgery.
Oh, wow.
So it's a problem.
Okay, so I'm gonna take me there, okay? Just say, hypothetically speaking, I'm a potential patient. So what do you tell me, what do you talk to me about if I am considering bariatric surgery? How does that conversation start?
Well, usually when I meet somebody and they're interested in surgery, one of the first questions they'll ask is, you know, when should I have surgery? How much longer should I just try to diet and exercise on my own? And the first question I'm going to ask them is, what is your BMI? And if it's over 35, if it's 40, 45, 50, and in round numbers, that patient needs to lose about 100 pounds, okay? So statistically, there was just a study released about 2 weeks ago. Now, this study was from United Kingdom. They followed patients for 9 years. They followed 67,000 men and 99,000 women over 9 years, okay? And none of these patients, none of these people had bariatric surgery. Now, the patients that were obese, meaning their BMI was 30 to 35, in that area, their chance of losing weight back to a normal weight over the 9-year period for a woman was 1 in 200. For a man, it was even less. It was about 1 in 250. In other words, if you ask me, when do you need surgery, I'm going to tell you as soon as your BMI hits 35. Statistically, you're not going to be able to do this on your own through diet and exercise. Now, the next criteria was patients with a BMI over 40, which is morbid obesity. Now, that's when the numbers really change. If your BMI was over 40 in that 9 years, if you were a woman, you had a 1 in 600 chance of getting back to a normal weight with just regular diet and exercise. And if you were a man, it was 1 in 1,200. So if you think you're the one person who can do it on their own with diet and exercise, lose 100, 150 pounds, I'll show you either, you know, 1,200 other men or 600 other women who didn't do it. So, you know, statistically, I don't want to rain on anybody's parade, but the odds are against you that without surgery, if you need to lose 100, 150 pounds, that it's going to happen with just diet and exercise. So if you tell patients that and put it into perspective, and they've been struggling with this all their lives. This is not some new, you know, thought to them. They know how hard it is. You know, I'll tell them that you need surgery sooner than later. You know, don't wait till your diabetes and your high blood pressure and your sleep apnea is really out of control. If you don't have any comorbidities, that's the time to do it. Don't wait till you're sicker. Get it while you're in the best possible health that you can be in. The longer you wait, as I said last week, statistically, the chances of you developing a comorbidity like I talked about goes up. So I tell patients to get it as soon as possible.
Okay, let me ask you a quick question. When a person is morbid obese, what does that mean, morbid obesity? What's the difference between that and just being obese?
So there's actually 3 classifications of obesity. There's 1, 2, and 3. Now, just to say to somebody's obese means their BMI is 30 to 35. That's obese.
Okay.
35 to 40 is severe obesity, and over 40 is morbidly obese, and over 50 is super obesity. Whew. Now, overweight is 25 to 30.
Okay.
So at 30, you become classified as obese. But at 35, that's when you're, quote unquote, a surgical candidate. In other words, you need to lose at least about 100 pounds. And as I said before, without bariatric surgery, the chances of you doing that are very slim. And just on that previous study, some patients did lose weight. Now, they looked at the patients, about 50% of the patients who lost 5% of their excess weight, 50% of them regained it back in 2 years. Now, that's in the UK study. Now, the studies here in the United States mirror that. Patients here have about a 5% chance of losing 100 pounds and keeping it off for the next 5 to 10 years. So it's very low. Statistically, the odds are not with you. Not that it can't be done, but I'm saying that there's more to it than just a diet and exercise. It's clearly a metabolic and hormonal disease, which is why surgery works so well.
Okay, speaking of surgery, what are the surgery options, or some surgery options?
So for surgical options, in this country, throughout the world, there's probably 3 that are the most talked about. The laparoscopic band, adjustable band, the laparoscopic gastric bypass, and the laparoscopic gastric sleeve. The gastric band was very popular 2000, 2005, 2008, kind of in that decade. It's not a very difficult procedure to perform, but as time goes on, the band patients seem to not do well with keeping the weight off, and their complication rate seems to grow over time. About 1 in 3 bands over the next 5 to 10 years will have to be explanted or taken out of the patient for one reason or another. Usually it's failure of weight loss or some technical complication like an erosion or a slippage or uncontrolled reflux. So the band has not done well long term with weight loss. That procedure warranted about a 30% of excess weight loss at about 3 years. Now, compared to gastric sleeve and gastric bypass, gastric sleeve, very popular right now, that procedure, it yields about a 50 to 60% of excess weight loss at about a year to a year and a half. Gastric bypass yields 70 to 80%. So there is a statistical difference between the 2 procedures, sleeve versus bypass. Now, I don't do the band anymore. I did a few early on. All the bands I actually have done, I've taken out and converted to gastric bypasses, and it was just a handful. So I only do gastric sleeve and gastric bypass at this point. Now, before I get into the exact surgeries themselves, let me say that ultimately surgery is the last resort. And so the data that I'm giving about surgical treatments, BMI over 35, and that's really what you need to have, that is true. But if you cannot let yourself get to 35, 40, 45 with a lifestyle change, more diet, more exercise, and stop the weight gain, that's always what I recommend. But if surgery is the last resort, it's the last resort, and that's what you need. So comparing the 2, as I said before, gastric sleeve, very popular right now. You go on the internet and you can Google it, and people are calling the office and asking me all the time, what's the deal with this new procedure? The gastric bypass is still the gold standard. The gastric sleeve is the new kid on the block. There's definitely a difference between the 2. The gastric sleeve, it is done laparoscopically. You'll have 6 small incisions on your abdomen. It's a procedure that essentially you're removing out of the body about 3/4 of the stomach. The stomach's kind of shaped like an oblong football, and you're turning it into a banana shape.
Okay.
So you're reducing the volume of of quantity that the stomach can hold. Now that is good, but it also has some risk factors. One of which is the pressure inside of the stomach goes up. Your natural stomach has a natural pressure of about 25 millimeters of mercury. When you sleeve it down to a narrow banana, the pressure goes up to as high as 38 to 40. So now if you have reflux and you sleeve the stomach, that could become worse. So you need to think about that. Also, you've got a long staple line that you stapled off the stomach and removed it. With a long staple line and elevated pressure, the chance of a leak is higher than a gastric bypass. So patients have to keep that in mind. The leak is 2 to 3 times higher, even though it's still low. It's still 1.5%. Gastric bypass is about 0.5. So there's a difference there. It's very low, but it's still a little bit higher. And the weight loss with this procedure is about 50-60% of excess weight. It's a fantastic procedure for the right patient. It does not involve any of the lower GI tract of the small bowel, just working on the stomach. So it does not have that full cascade of hormonal changes that the gastric bypass has. Now, gastric bypass, on the other hand, is the Cadillac. And I don't need to say that because that's what I do the most of. That's what the data says.
Okay.
I'm a scientist. I can give you my opinion, but I look to the facts. I look to the studies to see which procedure is performing the best, which one has the best weight loss and the lowest complication rate. The gastric bypass does not involve removing anything or putting in anything to the body. All I'm going to do is create a small pouch out of the stomach that's already there and connect the bowel to it. Now, there is rerouting. If I had a penny for every time someone told me, I don't want you to reroute my intestine, we'd be doing this show on an island down in the Caribbean, okay? You need rerouting. If your BMI is 35, 40, 45, 50, on up to 100, the route that you have is not working. That's what got you to where you are today. You need a rerouting, you just may or may not know it. The rerouting of the intestine, the bypass of the first part of the small intestine, is what gives you that cascade of hormonal effects that really affects obesity, your satiety, your appetite, your speed, your GI tract empties, your response to sugars, your glucose, the type 2 diabetics, the people with high blood pressure, things like that, PCOS, gout, all your hormonally related diseases, they get substantially better, if not go into full remission after gastric bypass. It is still the best procedure. Weight loss with the gastric bypass is roughly 70-80% versus sleeve 50-60% of excess weight at about a year to a year and a half. Now, one of the factual things that I look at, and I'll bring it to the audience's attention because I think it's good for them to go look these things up. The largest study was just released about 6 or 8 weeks ago called the Stampede study, S-T-A-M-P-E-D-E, Stampede.
Okay.
Now, when they do these studies, they like to put a catchy name on it. Now, Stampede stands for surgical therapy and medications potentially eradicate diabetes efficiently. That's what Stampede stands for. Now, this was done at Cleveland Clinic, which is a leader in research. And it's the biggest, most reliable, unbiased study there is. And what's special about this study is it's the only study that directly compares gastric bypass to gastric sleeve to medications. And they look at the outcomes: weight loss, control of type 2 diabetes, patient satisfaction, and number of medications the patient is on after 3 years. Compared to gastric sleeve and medications, the gastric bypass statistically still has the best percentage of weight loss, lowest complication rate, patients were on the least amount of medications, better control of blood sugar and type 2 diabetes, and the number one thing that I look at was their lifestyle patient satisfaction. The quality of life of the bypass patients was statistically higher when questioned than the sleeve and the bypass. And ultimately, that's what this is all about. Quality of life. That's why we do this.
Well, let me ask you this. This is so good, and I really appreciate you so much for this. Why would a person opt for the sleeve versus just the gastric bypass? Is there a reason a person may get a sleeve versus just the gastric bypass?
There is. When you consult with a patient and you're going over the options of surgery, my job as a surgeon is not just to be a technician, not just to do the surgery, but to know about it, to know what to tell the patient to expect after surgery. So ultimately, I always leave it up to the patient to decide. But I have to make sure from a professional standpoint that the patient has all of the factual data. And most time when patients come into the office, or I see them in a seminar or something, they won't have the facts. They'll have some anecdotal story about their aunt whose coworker in New York had a bypass in '94 and died. Some strange or they'll have a family member who had a bypass in 2002 and can't eat anything. See, these are one in a million stories. You don't hear about the 99% of patients that did fantastic with gastric bypass. You hear about the 1 in 100 that didn't do well. So it's my job to give them the right information. And so when I talk about the Stampede trial, or I'll talk about the risks of leak and and gastric ulcers and small bowel obstruction and acid reflux, the risk factors that go along with the procedures. I give them the data and they have to decide. Now, sleeve patients or patients who are going to get a sleeve in general probably have a lower BMI, 35 to 40, and they don't have a lot of comorbidities. They don't have type 2 diabetes. They don't have high blood pressure, sleep apnea, things like that. And those are good sleeve candidates from a medical standpoint. Once the BMI is 40, 45, 50, gastric bypass is the best operation. Now, if somebody is just set on getting a sleeve or getting a bypass, and that's what they want, and I can't really give them any real data to say they can't have that, then the patient ultimately decides, and I'll do what they want to do. But I want them to have the facts before they make that decision.
Okay, well, if you're just joining us, we're a little bit over halfway through the show, and I have with me yet again one of the masters, Dr. Robert Wegner, and of course, he's with St. Francis Weight Loss Center. And we're talking about surgical options for those of you out there that are considering, you're fighting this battle with your weight and you want to feel better, you want to do better, you want to get rid of a lot of those health problems that you have. Dr. Wegner at St. Francis Weight Loss Center, he's your man. Okay, this is exactly who you need to see. Now we're going to go into, we just finished telling us about gastric bypass and the gastric sleeve.
Yes.
But now we want to talk about recovery and what foods, what's the lifestyle going to be like after post-surgery?
So the patients, after surgery, or actually before surgery, they'll ask, if I get one procedure or the other, what's the difference in recovery? What's the difference in lifestyle? What's the difference in the foods I can eat? And I just have one word for them: nothing.
Okay.
There is absolutely no difference between the sleeve and the bypass post-operatively. In other words, if you just saw the incisions, which are also identical, and you ask the patient, did you have a sleeve or a bypass, unless I tell them what I did in the operating room, they would not know. In other words, that's how similar they are for the patient for the rest of their life.
Okay.
Their post-operative time is about 2 nights in the hospital, roughly 2 to 3 weeks off work. That's just to let the incisions heal. Every patient must take a multivitamin, a calcium, and a B12 every month. The other ones are daily, and iron to supplement their diet. And that's bypass and sleeve. There is no difference there either. That's another common misconception. And the food choices obviously have to change. Not just the quantity of food, but the quality of the food.
Okay.
So what I do post-operatively to let everything heal is you just want to slowly advance the patient. So I'll do a week of liquids, then a week of soft, and then a few weeks of pureed. And by 6 weeks, the patient is back on a regular diet. When I say regular diet, I mean they're eating meat, they're eating vegetables, they're eating fruit, they're doing their protein shakes and their vitamins, they're doing all the things that they've learned getting ready for surgery. But it's really the volume of food that changes, and also how they eat it. You've really got to chew your food much better than what you're used to in the past, not just taking 2 or 3 bites and swallowing. You've really got to mash that food up in the saliva and get it down into the stomach or into the sleeve or into the stomach pouch or the stomach sleeve, because the volume you'll be able to eat is very low and the digestive process is going to be a little bit different. So you want to really work on chewing your food really well, not drinking with your meals, and these are little tips that we teach the patient along the way so that they're successful after surgery.
Okay, so overall, because I know everybody wants to know this, so how do I expect for my lifestyle to change after I have this surgery?
Hi, I'm Angelica reporting live from LaMarr Productions in East Memphis. Thanks for watching. Let's talk with Betty LaMarr.
Well, you can expect, if we look at a graph over time, the weight loss is not linear. It's stepwise. And if you graph it out, there's a linear line that you'll see, a decrease in the weight. But it's actually a stepwise progression down. So you'll lose weight, and then you'll plateau. And then you'll come to another step, and then you'll plateau. And those plateaus may last a month to a month and a half, maybe 2 months, and then you'll drop some more. And patients will generally see, if you average it out, a weight loss of 8 to 10 pounds per month, which is fantastic. They've never seen that before. But the thing is, the weight stays off this time. Yes. But this is not a magic bullet. and this is what I said on the first show, and I'll say it again. Lifestyle changes have got to be made. You cannot just get the surgery and keep eating what you were eating before the surgery and not doing any physical activity like you were doing before the surgery.
Right.
So when I say diet and exercise, those are key components to the success of a gastric bypass or a gastric sleeve. The patient has got to understand that. This is not just a magic surgery. You can come in and get it and like, oh, I can go to McDonald's and go to the rib joint and eat the fried foods and expect it to work, because it won't.
Okay.
You have to eat the right foods, take your vitamins, a little bit of exercise. It's not difficult, but the patients have to commit to that.
True, because you know how we are as humans. We'll do all the wrong things, but we're going to blame the doctor.
Yes.
We're going to say Dr. Wegner did that to me.
Right.
We're not going to say we went to McDonald's immediately after
I'll
surgery.
get it out of you, though.
Yeah.
If a patient comes in, surprisingly, and they're 6 months, a year, year and a half down the road, and I saw initially that they did fantastic, but maybe a year down the road we see a little bit of weight gain. If we really sit them down and talk to them openly and intelligently, 9 times out of 10, they'll open up about that they haven't really been as compliant as they should with the food choices that they're making, or the amount of exercise or activity they're supposed to be doing. So we can usually pinpoint, what the problem is, and we'll kind of, gently encourage the patient to get back on the lifestyle changes that they signed up for, and then the weight will start to come off again.
Okay, within the last few minutes, of course, I'd love for you to wrap the show up, because you're going to tell our viewers exactly what we're going to do on the next segment, because this is a series that we're doing, because this disease, obesity, is very, very important, because it's all about your health and wellness. You need to make your body a priority. So I had one of the viewers to say, would you tell Dr. Wegner this for me? He's told you on the last show that, Betty, this is not a vanity thing. It's not about looking good in a dress. Mm-hmm. She said, but you tell Dr. Wegner, I need to have a gastric bypass because I do want to look good in the dress again. So we had a good laugh about it, but she's also having some health problems. But she said, but I do look forward to looking good in a dress again.
Right. Who doesn't? Who doesn't want to look good?
Exactly. But she really needs to be healthy. She really wants to be healthy.
Yes.
So now, if you will, please, in this last 2 minutes, tell our audience what they're to expect on part 3 or the next segment of bariatric surgery.
So we've done 2 segments, last month and this month. First segment, was just talking about obesity in general terms. I think this segment, we try to cover the actual treatments, the actual surgical treatments of obesity, and talking about gastric sleeve and gastric bypass and comparing and contrasting. Next segment is going to be even better, because it's one thing to hear it from me, the surgeon, the technician who does the surgery and this and that. It's another thing to hear it from someone who's been through it.
Thanks for listening to Conversations with Betty LaMarr. Visit our website, www.thebettylamarrshow.com. Email betty@thebettylamarrshow.com. Subscribe to our YouTube channel, Betty LaMarr Memphis. We'll talk to you next week on